Hi there guys, it's Uzo Ehyog here from Integrated Clinical Strength and Conditioning. In this very short video tutorial, what I'm going to do, I'm going to talk about some of the tools that we have available that we can use in clinical practice, to document change within our patients. Now, so outcome measures, everyone talks about outcome measures. Yes, we need to collect outcome measures, but in our busy clinics, we also got to be realistic, around what's collectible, what's useful, and what's going to inform our practice, as physiotherapists. So, and I break it down into two, essentially. We've got qualitative tools and we've got quantitative tools. So, in the past and of recent, I would say that we seem to be less reliant on our qualitative tools, or maybe it's just not so fashionable. And what I mean by that is, I'm an ex-military person, and observation, Mark 1 eyeball, very, very important. And what I mean by that is, often, there's a lot to see, and we can look at how people move qualitatively. And what I mean by that is their movement quality. Yeah, I know it's a dirty word, movement quality. Why? Because it's really hard for us to define movement quality, and the scientists among us and around us will say, but if you can't measure it, then you can't manage it. Well, fundamentally, you can measure it, We've all got phones, our patients have phones, with most iPhones and iPads, we can slow things down to the nth degree. So you can measure it, that's the first thing, But I say again, the therapist's eye or the coach's eye is very, very important, because you can look at somebody doing something, walking up the stairs, running into a 35 degree or a 40 degree cut and trying to change direction, you can look at someone doing a sit to stand and you can just look at it, even as a newly qualified individual, because let's be honest, we've all been on this planet for at least 20 years or 23 years if we're currently a physiotherapist, or a physical therapist. So you will have seen numerous people over the years who have done these particular tasks. So it's easy to look at someone and say, well, fundamentally, does that movement pattern look good? It's a simple yes or no, If you say it doesn't look good, the next question you need to ask yourself is, why isn't it? Is it because, actually, the mechanics don't look good? And often it's because of the mechanics. Intuitively, we will look at something and we'll say, there's something I don't like about that, I'm not quite sure what. And it might be that actually it's about their kinematics. It's about the actual movement, the way they move, It's about the quality of their movement that you're looking at. Maybe it's about their posture and the shape. The shapes that they're making, don't look particularly efficient. Which then takes us down the kinetics road, And you don't need a degree in biomechanics, to work this out. We ask ourselves three simple questions. One, does it look like, they are generating an optimal amount of force to do that particular task? Yeah? So are they dragging their leg as they're walking upstairs, as an example? Does it look like they're transferring force through their feet, if we're using a walking example, through the chain? Yeah? Does it look like they're transferring force? Or actually, is their trunk moving up off to the side, as they're trying to push through their knee, to step up onto the next step? A simple thing. Or does it look like, they're having problems absorbing force? So they're walking down the stairs and actually, they're not bending that knee well. It doesn't look like they're really accepting that load well. So there are the three things. Can they absorb? Can they transfer? And can they generate force? They're the first three fundamental things. And does it look good? Yeah, as simple as that. It's a simple yes or no answer. Then we move on to more quantitative measures. Now, Obviously, from a quantitative measure, often what we're looking at, okay, is we're looking at the kinetics rather. So we're looking at the management of forces, basically. Okay, whether we like it or not. I know biomechanics is a bit of a dirty word. Okay, in some sectors. Okay, you don't need to be a biomechanist, but we do need to accept the fact that force is what allows us to move. Full stop. Whether we like it or not. It's an uncomfortable truth, but it's a truth nonetheless. So, what we're often looking for is we're looking at force, okay, and different sectors of that force. So, the most obvious one that we can use, okay, is to measure muscle force is the MRC scale, okay, from 0 to 5. Well, that's just, we were taught that in physio school. And for most people, that will suffice. Let's be absolutely honest, and most people that will suffice. But actually, nowadays, it's quite easy to get a hold of inexpensive dynamometers or stress gauges, or strain gauges. Okay, a dynamometer is pretty inexpensive. Okay, you can now pick up really good dynamometers, okay, with digital readouts that essentially, okay, Bluetooth to an app on your phone or your iPad, okay, for about £200-300 or $200-300. Okay, so they're relatively cheap. Okay, so gone are the days where it was £1,500, okay, to buy a dynamometer. Now you can pick one up for £200. Okay, that's basically, okay, a very expensive night out, but nonetheless it's great because it then means that actually you can really objectify the patient's muscle force. Okay, yes, it's isometric, but still it's giving you a bit of a read, isn't it? It's giving you a read on how the patient's functioning. The second thing, okay, is that's just looking at force production, i.e. strength, in a very isometric way. But there's other things we can do, isn't there? So we can use things like repetition maximums. Okay, so for example, if we use like if we use, say for example, the heel raise as an example. Okay, so you've got someone that has Achilles tendinopathy and you use a heel raise. Okay, the good thing about the heel raise, okay, is that actually you can simply look at the force decay. Yeah, so what I mean is you can use, well, how many reps can you do, okay, before you've got none in the tank? Okay, so that's a test of endurance. Obviously, there are other things as well, okay, such as rate of force development. Well, there are various apps available, okay, now that you can download to your phone, such as My Jump, as an example, okay, or you've got other modalities like you've got linear transducers, okay, so the push bands and such like, okay, which measure power output and velocity, okay, via jump height or via how quickly a particular body segment has moved. Okay, now the key thing here is you don't need those, okay, for most of your patients, but these are objective, okay, or quantitative measures of muscle performance, okay, that work across the continuum, okay, and obviously the thing I've left out is muscle girth. We can obviously measure muscle girth, okay, providing you've got a tape measure. Ideally, that tape measure should be aluminium, okay, so that it doesn't stretch. But not many of us have an aluminium tape measure, okay, in our clinics. They're relatively inexpensive, but fundamentally what you're aiming for, okay, is you're aiming for something that gives you a marker. Now, obviously there's a relationship between muscle force, okay, and cross-sectional area of muscle. Okay, so you could technically use your isometric muscle testing, whether it's, okay, with a handheld dynamometer or using the 0 to 5 scale as a proxy, okay, for an increase in muscle girth. It's not perfect, but it gives us some indication. So, you heard it here first, okay? We've got loads of tools available to us, both quantitative and also qualitative, that we can use to make sensible decisions, okay, about how we progress and regress, and also how we help our patients to achieve their functional goals, okay, and to improve their fortunes. Thanks for listening. Bye for now.